Good afternoon, everybody. I'm Sebastiano from NOVAVIA. It's good to be with you today. So welcome to this online International Knee Congress that we organized with 3 top-notch speakers. This is a cooperation between the NOVAVIA Project, LaFisioterapia.net, and Guida Galattica per fisioterapisti. So this is a free content, will be available online, and it's actually following what we already recorded past week. It was again an online international upper quarter congress. So if you are interested to that congress as well, just search on our official pages on social networks, Facebook, etc., and you will be able to track the link and have access for free also to the other congress. So the idea basically in this weird period under this pandemic, we decided to create good quality content free online. And we ask very talented experts from all over the world to join us. And we have been lucky enough to have today 3, as I said, top-notch clinicians and researchers, such as Lee Herrington from UK, Lars Engebretsen from Norway, and Bart Dingenen from Belgium. So more initiative will come like this one, but let's focus on this one for today. So this is what's going to happen. They will present a presentation, each of them, and we will introduce the topic later on. And then at the end, there will be a Q&A session, and we will pose them your questions. So when I say your questions, I mean you that are watching this Congress now, because we anticipated online the topics. So you guys in the last 2 days knew what they would have talked about. So you will have the chance to listen to their answers to your direct questions. And now it's the time to pass over the mic to Paolo.
Thanks, Sebastiano. I'll be very brief before handing over to our first speaker. Obviously, thanks again to this partnership between Guida Galattica per fisioterapisti, NOVAVIA Project, and LaFisioterapia.net. We organized a second international event with these 3 top speakers, and this time our focus will be on knee injuries. I've really enjoyed being part of this project, and I hope everyone will enjoy their time listening to these amazing presentations. Obviously, feel free to share the link of the event with your colleagues and friends, and obviously follow us on our social media pages. And stay in touch with us, because there will be more events coming up in the future. Now, even though I know it needs no introduction, I'm really pleased to welcome Lee Herrington, our first speaker. Lee is a physiotherapist and senior lecturer in sport rehabilitation at Salford University, where he's program leader for the MSc in sport injury rehabilitation. He's a technical lead physiotherapist with the English Institute of Sport, leading on issues related to lower limb injury rehabilitation across all the Olympic and Paralympic sports. But he's also consultant physiotherapist to Premiership and Championship club and rugby union clubs. He's lead clinical researcher in knee biomechanics and injury research program at Salford University, with specific interest in anterior knee pain and rehabilitation following knee surgery, in particular ACL reconstruction. He's published over 200 peer-reviewed papers. But I will pass on to Lee now, who's going to present about old knees in young athletes.
Thank you, Sebastiano and Paolo. So my talk is going to be old knees in young athletes. So it's probably pertinent while we are in this this strange lockdown world where we have a lot of athletes who are not training as much as they would be. So hopefully you'll be able to take something of the talk as well into our current situation alongside the main topic, which is these athletes we have who have these almost pre-arthritic knees following on from previous injury or just a life in sport. So if we look at what the problem is, what we know at the moment is certainly our ACL reconstructed patients, we will have a large group of them, anywhere between 25 and 50%, report ongoing knee symptoms. And in a high proportion of these knee symptoms are the things which prevent them returning to performance and sport. And what we know is that there is a sequelae which happens maybe a decade later, where they go on to get tibiofemoral or patellofemoral osteoarthritis. So we possibly have early symptoms which then progress into some significant pathologies. And we know this is not only true for our ACL population, but it's true for our meniscectomy population and possibly the other knee injuries. So we have a post-injury sequelae into a symptomatic knee. What we also have in these sports people is quite often a large number of asymptomatic findings within the knee on MRI with changes in the articular cartilage, meniscus, and bone marrow lesions within the subchondral bone. And so that then leads us to perhaps we have another population who, because they've got these early degenerate changes, might be more vulnerable to impact and loading within their world. And then if we take into account these bone marrow lesions, when they are present, may influence articular cartilage homeostasis and health and tissue health, we perhaps start to have a sequelae where we're getting problems. So if we look a little bit around the background and the underlying cause. So this altered loading could bring about changes in the subchondral bone, and what we can see is we can have an inciting injury, which causes an overburden of the tissue, which causes further damage, and then leads to altered bone formation. We get changes at the subchondral interface, which could then cause alteration in the nutritional supply to cartilage and cartilage degeneration. So this is one route where we might start to see problems in early OA. Another route is actually at the bone level, where the bone possibly isn't as able to cope with loads in the same way. So we know post-ACL surgery, there's been work which has shown decreased trabecular density and bone mineral density, so the bone is possibly less able to support load. We then get these bone marrow lesions developing at the sites of traumatic loading, so at these areas of potential weakness. These bone marrow lesions then have the potential to create venous stasis because of the increase in pressure. This may restrict venous return, which further increases interosseous pressure, decreases the arterial blood flowing into the area, which then could create tissue hypoxia. This then alters the perfusion across the subchondral bone and causes cell death. So we have a couple of mechanisms whereby these alterations in local bone and joint could create ongoing degenerate problems. So that's the sort of theoretical background, if we like. So what do these patients present like? Well, typically what we will see in these individuals is they will have a low-grade ache most of the time. They will have a minor effusion. They will have pain usually after activity, and they will be stiff in the morning, and they perhaps will struggle to get going a little bit. So they will look like an osteoarthritic patient or a low-grade osteoarthritic patient. And then what they will get is an acute episodic pain, usually related to a spike or an increase in loading. They will then start to get significant effusions. The pain they get will limit activity. They will tend to have muscle inhibition. They will start to have a lack of confidence in the knee. And the solution to this problem generally is we will modify or restrict their training activity. But this modification or restriction of their training activity then could reduce their chronic load. So what we then is we get into a vicious circle of essentially detraining the ability of these underlying tissues to actually tolerate load. So we get in a sequelae of, because they have restricted chronic training load, they are more easily acutely spiked. So they become irritated more easily. So we get into a circle of events. So we're gonna talk loosely now about how we might sort of try and break into this situation where we have decreased activity. The decreased activity can develop muscle atrophy and inhibition. and this leads to altered movement patterns, which then perpetuates the joint damage. So how we might break into this cycle. So in terms of early management, the first thing probably is we need to reduce load, but not to unload. What we need to do is try and establish what is a stable baseline for these individuals. We need to find a level of load the joint is able to cope with, and not necessarily take them back to zero load because of the difficulty in then reloading them from such a low base. We could consider taping and bracing, and Mike Callahan's group at Manchester did a very interesting piece of work where they took osteoarthritic patients and they applied a very basic neoprene knee brace to patients who had overt bone marrow edema. And within 4 to 6 weeks, what they found was these patients, on only wearing the brace, had decreased volume of their bone marrow edema, which also correlated with a decrease in pain and an increase in function. So what we should be able to do is probably take that information, use taping or bracing to possibly manipulate their internal environment, so we can start to change the knee loading and possibly the bone marrow lesion. We have our other modality, which is ice. And what we see, and we regularly use thermal imaging now in a lot of our patients. So this is a thermal image of a knee, and you probably won't be able to see the temperature marked up there. It is 25 degrees in an asymptomatic knee. And in the symptomatic knee, again, you probably won't be able to see the temperature, but it is 30 degrees. And what we have is someone who did a fairly simple loading task. They actually just ran for 5 minutes. And what we got was a significant difference in temperature in the knee. So it would make sense that if we can cool these knees, we have the potential to possibly influence this aberrant thermal reaction we're getting at the time. We also probably need to work with our sports physicians and make sure these athletes have got healthy bones. As we said, the post-ACL group has shown some bone mineral density changes and some trabecular changes. So we probably need to understand their vitamin D status and also their energy balance. And again, negative energy balances in these individuals can affect bone health. So we need to work with our nutrition team and with our sports physician team to make sure we have healthy bones to start to build our rehabilitation on. And then finally, in the early phase, we probably need to consider how we might overcome quadriceps inhibition and develop quadriceps. And then once we've overcome the inhibition, develop quadriceps strength. So if we look at overcoming the inhibition, there are a few modes we can use there. We can use muscle stimulation. And by a superimposed twitch, what we mean is the athlete volitionally contracts their muscle at the same time as the muscle stimulator is active. So we use the muscle stimulator to superimpose their isometric twitch. And again, what we know is if we use appropriate ranges of movement, we are likely to generate greater torques or greater muscle activation. So therefore, we are more likely to overcome the inhibition. So again, we want to be doing this superimposed twitch in the range of 60 to 90 degrees, where we can get the greatest activation. What we also probably need to do is look at means we can use to reduce pain in the joint. And so submaximal isometric contractions will bring about hypoalgesia, and we could use this before we then go on to then do our maximum contractions to start to work at the inhibition. Similarly, we could ice the joint prior to exercise, which again may act to relieve pain and set us up for a better chance of generating a high level contraction. We can use physiological mechanisms such as crosstalk. So what we have set up in the picture is the athlete is doing an eccentric contraction on the isokinetic dynamometer, which obviously generates a very high force. We then get crosstalk or a physiological leakage into the injured limb, and they then use that to try and generate as higher isometric contraction as possible at the same time as they are eccentrically working their uninjured limb. So again, we got crosstalk. you don't have an isokinetic dynamometer, we can do this with lifting and lowering weights in a quads bench, or even with an isometric with the contralateral limb. We can use whole body vibration, and whole body vibration plates, again, will stimulate the quadricep through the reflex arc. So we have a number of tools where we can overcome quadriceps muscle inhibition. Once we have overcome that quadriceps muscle inhibition, then what we should be able to do is start to strengthen the quadriceps. And here we want to isolate our quadriceps work as much as possible. So obviously, to isolate it, we can use open chain quadriceps knee extension based tasks. If we go through the pictures from right to left, as you're looking at them, we can use terminal extension strategies. So we're using the band there, and they're just terminally extending the knee to try and generate work in the most inhibited range. The middle picture is doing the so-called Spanish squat. So what that individual is doing is using the bands to maintain vertical tibias while they essentially sit backwards and then bring themselves back up into an extended position. And then we have on the right the classic decline squat, where we are looking to load the knee, and this has been used for patellar tendinopathy, but is very useful for generating work at the quadriceps. And the Spanish squat and the decline squat work best if you can maintain as upright a trunk as possible, so you are maximizing the distance of your center of mass away from your axis of rotation or your knee joint. And this is how they impart the greatest load going through the quadriceps, because if we lean our trunk forwards at all, we start to unload the knee relatively and load the hip more. And what we want to do is load the knee maximally in these examples. And then the Spanish squat and the decline squat are also very good for emphasizing eccentric loading, and we need to emphasize that eccentric loading before we get onto load acceptance. And what we find in this patient group is quite often they will have a dyskinetic eccentric contraction. In other words, they might look quite strong concentrically, but actually they fail to generate consistent and useful force eccentrically. And then we can build in load acceptance, or fundamentally landing on the leg. And if we look at the example here, these are almost all the things we want to do. And we typically look at this as risk for an ACL or as risk for a patellofemoral joint problem. But it is also a very ineffective strategy for loading our quadriceps eccentrically, because what we're doing, Tim Hewitt and Greg Meyer coined the phrase a ligament strategy. But what it is quite a passive strategy to load the limb, because they're going into hip adduction. They are putting a lot of load through their ITB. Because the foot is pronating, they are putting a lot of load through their plantar fascia. And because they are dorsiflexing the ankle rather than flexing the knee, they are putting a lot of load through their Achilles tendon. So they're using the passive elastic structures of the limb to absorb the force rather than actively absorbing the force through the quadriceps. And then the movement pattern as well will obviously heavily load our tibiofemoral and our patellofemoral joint compartments. So we want to look to get correct load acceptance. And we want correct load acceptance before we work them into more functional activities such as running. And if we're going to progress towards running, we need to build a load tolerance. And probably what we need to consider here is what we call the 1,000 squat rule. If we think about 10 minutes running, we would typically have somewhere between 800 and 900 foot contacts. If prior to this, we've been getting our patient to do 100 squats, 4x25 or whatever we are choosing to do in our session, that is not building up the load tolerance to be able to deal with 10 minutes of running. Even if we've done some landing drills, we are still likely to have nowhere near the load tolerance or the chronic capacity to start to deal with even 10 minutes of running. Hence, we developed the 1,000 squat rule. And what we would want our individual to be able to do within a session is 1,000 squats. That's not 1,000 squats in one go, obviously. That would be, it could be 10 by 100, it could be 20 by 50, it could be 40 by 25. My maths is going to run out very soon. But what we want, and that doesn't need to be a single version of a squat. We could do decline, we could do Spanish, we could do standard squats, we could do step ups, but they have a volume of capacity to deal with the load which starts to resemble running. And then once we are running, we probably need to consider some of the things around running. The first thing is running is not as stressful on the knee as walking, which is surprising. So if we are returning somebody to running, one of the things we need to consider is, are we restricting their walking a little bit at that time to allow them to concentrate on building their running load? Because if we have someone who's doing a lot of walking and then running, we might blame the running on their flare of their knee. But actually what it could be is the fact that they're doing a lot more walking and loading the limb over the whole day. So we need to consider their global loading pattern, especially the mixture between walking and running. And the other thing is, we probably shouldn't be sending these people out to do a very slow jog, because again, the cumulative load when we run slowly is far higher than when we run relatively quickly. So what we should be doing is having these people running at their normal running speeds. We shouldn't be taking them to slow jogs as the return strategy. And then one of the other ways people have brought back running is to look at alternate loading environments, such as Alter-G or reduced weight running. And again, what we've got to be careful of here is these environments are great, but as we start to progress towards we're only reducing the body weight by 10%. The loads are pretty similar to as we would run on a normal treadmill anyway. So we should be looking at integrating normal overground running with Alter-G as we're starting to move them towards normal body weight, or again, we won't be preparing them for the impact loads. And then what we also need to consider is the meso macro cycle planning, and what we say is pinch point. So how does the week look? Do we front load the week so they can recover towards the end? Do we know that they're doing a lot of steps at work and a lot of standing at work? So perhaps what we do is we put their running loads into the weekend where they can recover better after the running loads. So how does their week look? How does their training month, 2 months look? When are they going to be playing a lot of games? So traditionally, we would play a lot of games over the Christmas period in a lot of our team sports. So how do we prepare the athlete to deal with the worst case scenario, those multiple games in a short space of time? And what we need to be doing is thinking way ahead of these pinch points, so how we prepare the athlete to be able to cope with them. So, and then the final thing to consider is, how do we know when things are going wrong? It's a little bit late when we have this acutely effused knee, when they can't actually take a lot of load through it. We really want to monitor them more closely. So we use a couple of things for monitoring. We use morning stiffness, and we base that around their squat. So as they first get out of bed, we would get our athletes to squat fully, and we would get them to compare that to what is typical for them and if they are stiffer than normal. We would get them to report their pain on first mobilizing in the morning, their pain on mobilizing after training, and their pain on mobilizing before they relax for the evening. And finally, we would get them to measure their knee circumference first thing in the morning as they wake, and then last thing before they relax for the evening. And what we have here then is we have some tools. If they are becoming stiffer, if they are getting more noticeable evening or morning pain, if their knee circumference is changing a lot over the day, we're probably getting a joint which is becoming irritable. And we probably need to think how we can intervene and possibly change their load. And also alongside that, we regularly want to understand what their quadriceps strength is. So we can use isokinetic dynamometers, handheld dynamometers, even simple things like pressure biofeedback squeeze tests, in order to regularly check that they are not starting to get inhibited or detraining their quadricep and not maintaining their quadricep strength. So to conclude, with these athletes who are predisposed to irritability within their joints, we need to acutely manage their nodes. So we need to take them to a level of load they can cope with. We then need to carefully manage their load through reloading. And in the long term, we need to think about maximizing the load these individuals are exposed to and maintaining as high a chronic load as they can cope with, because then they will be more resilient to those acute spikes and the pinch points in their season. We need to remember about their joint health, and we need to work with our sports physicians and our nutritionalists around supplements and vitamin D and other things to make sure their joints are as healthy as possible. We need to absolutely always have built into their program quadriceps strengthening, triple extension strengthening with an emphasis on eccentric control. And finally, we need to make sure we monitor regularly and intervene as they start to drop off and their knee health is changing. So thank you, and I hope you've enjoyed the presentation, and I'll hand you back to Paolo now.
Okay, thank you very much, Lee, for your detailed presentation. Definitely, as we all appreciate in these years, reading your papers, a lot of references. So it's opening a paper or a presentation of you is always having access to a world of other papers and presentations. So thank you very much. I'm sure people will enjoy that. So, and now let's move on to the next presenters. We are very pleased to have here today Dr. Lars Engebretsen from Norway. Lars is an orthopedic surgeon, researcher, and professor. He's currently professor and chief of research at the University of Oslo, professor at the Norwegian College of Sports and Physical Education, and co-chair of the Oslo Sports Trauma Research Center, chief of sports medicine at Norwegian Federation of Sports and Olympic Committee at the Olympic Committee and Paralympic Committee, and head of medical sciences at the International Olympic Committee. Lars has published over 300 articles and book chapters and continues to be very active in clinical, epidemiological, and basic science research in the areas of general sports medicine, knee ligaments, cartilage, and prevention in sport of sports injuries and illnesses in general. He has received research grants and awards from many agencies and associations, including the National Institute of Health, the Norwegian Council for Research in Science and Humanities, the Norwegian Ministry of Health, and the International Olympic Committee, so the IOC. Lars works in 3 research groups. One of them is based in the United States and 2 obviously in Norway. And today Lars is going to present on the role of the ACL registry in Norway. So it's up to you now, Lars. Thank you.
Yes, thank you for allowing me to speak to you today. I'm going to talk about ACLs and the Norwegian ACL registry as a basis for the model we're using here. So, you know, I'm a clinician, I do surgeries, I do lots of ACLs, and also all kinds of more complex knees. But I also work very closely with the physiotherapists. So I thought it was very fun to listen to Lee. And I actually, he taught me a few things, so I hope I can get to speak to him later on. My disclosures are like these. I'm a researcher. I have 500 papers on PubMed and so forth, so I've been doing a lot of research over the years. I work at the Oslo University Hospital, which is a level 1 trauma hospital in Oslo. I've been chair of the orthopedic department for many years, and since I started with the IOC, I stepped down, and now I'm just a professor there. And I work also at the Olympiatoppen, which is the Norwegian sports medicine high castle, I should say. And this is right here, and this is where I work currently. This is the Olympic Center, and here's our research center. and I live just down the hill down here. This is great for biking and skiing and everything like that, cross-country skiing, I mean. So I work in a very interesting neighborhood. And Norway is a small country, as you know. We only have 5 million people living there. And here we have Norway, Sweden, and Denmark is down here. Finland is over here. And Norway has 5 million people. And in 2000, we started to develop an ACL registry because I wanted to be able to register what happened to the knees that we did surgery on. And that's what I'd like to go through with you here. Now, Norway, Sweden, and Denmark has about, each of them have about 5 and 10 million people. And here you can see that we have about 70,000 ACLs in the registry from these 3 countries in 2017. The mean age of the people we do ACLs on are these, and the majority are actually males here. And when you do the ACL when I do the ACL in my surgery, I have to fill out this registration form, which I'll tell you a little bit more about it later on, but now it is all web-based. And you log in, and the surgeon, after the surgery, fill out this, what kind of findings we have and stuff like that. So we know everything about the patient. And then we look at every ACL reconstruction, PCL reconstruction, everything related to that, revisions, reoperations and stuff like that, has been are registered into the registry. It was voluntary from the surgeon, but since 2015, it's now mandatory by the state to report. And in Denmark, actually, you don't get paid unless you report it. So it's a very important thing to do. So everyone is doing that. Let's look at the compliance here. I know that's an issue in Italy many times, and in Norway, it's not perfect either. And the overall compliance, meaning that we are registering all the ACLs we do, is not perfect. It's about 84% have been registered around the nation with 55 different hospitals. So we're okay, but not perfect. And you know, when you look at the registry, and you look at the results you can find from it, which I will show you a few of, you can also always compare that to randomized control studies. They are many times the gold standard of our research in clinical medicine. And the registries has come since about 2000 in, at least in ACLs. And the registries, their really positive models is that they reflect the clinical reality. There are no selection bias, large cohorts, low overall costs, whereas the randomized studies are few patients and very few, 1 or 2 surgeons and so forth. So there's much big numbers in the registry, and you can get much more information out of it, but not as perfect information as you get from a randomized control study. So no one is better than the other, and both are needed, and both are being done as we speak now. Now, this study, randomized control study, I started 30 years ago. 150 patients, 3 different ACL groups, 3 different surgeries, techniques, and we just followed them for 30 years and just published it. And of course, that's a very important thing, because now we know how they do 30 years down the road, all the complications they've had, who does better than others, and so forth. So that may be a better way of looking at specific things than a registry. Now, in the registry, we have now 70,000 patients in Norway, Sweden, and Denmark altogether. There's been more than 70 publications from it, so it's quite efficient. Now, the reason for having a national registry is that we can provide feedback to your hospitals, your surgeons. We can detect procedures and treatments that result in inferior results. That's, of course, the most important part. And we can identify prognostic factors associated with good and with poor outcomes. That's the main thing here. There's also some statistical issues here, and that's one reason why registries are good, is that their statistical area is quite good as well. And this is the data we get from the surgeries we do, or from the patients we don't operate on that has ACLs. We get the etiology of it, we get previous injuries, associated injuries, we get the methods that we do. I'll get back to a few studies on that. We look at the meniscus, we look at the cartilage, and we look at surgical time. Are we using antibiotics? Are we using NSAIDs? Do the patient get antithrombosis and so forth? So we also, not only the surgeons are filling in forms, the patient also filling forms. We use the KUS knee survey. You know, you may not be familiar with that. I'm not sure if you're using that so much in Italy. I know they're using it somewhat in Belgium and in England. And this knee injury and osteoarthritis outcome score has been filled out by the patient at time 0, 2, 5, and 10 years. So we do get a lot of results from the patients. Now, after I described a bit on the system, so what have we learned from the registry? Let's look at that a little bit. Well, if you have an ACL and then you have a meniscal and you have a cartilage injury, what happens? Well, the bigger the cartilage injury is, the poorer this KUS subscales, the subjective form of the patient, is also. So the bigger the cartilage diversity is, the real big ones are in patients with young age. They're males, specifically male team handball players in previous surgery, and also if the time from injury to surgery exceeds 12 months. These are the patients that go through the surgery. Now, the odds of having a cartilage injury is increasing by 1% for each month that goes between the injury date and the surgery date. So it's so important to, if you're going to do surgery, you're not going to do that in everyone, obviously, but if you are, it is important that you time that as soon as possible after the injury. And I can get back to that a little bit because we never do it acutely, actually. We do it after they have full range of motion, no swelling, and usually 6 to 8 weeks after their injury, unless they have repairable meniscal tears. Now, talking about meniscus, if you do suture the meniscus, the results on the subjective scores are not as good as if you don't have a meniscus tear. But if you don't repair it and you take out the meniscus, it's even worse. So that is important. Now, what about KUS? KUS, the subjective score, is an important one because if you score on quality of life, for example, that's one of the 5 subscores, you get less than 44 points, then you have a much higher risk for having a revision down the road. And then for every 10-point reduction you have in the KUS score, you have a much higher risk for higher revision. So you can talk to the patient based on the score. So KUS is very useful as a predictor for this. Now, predictor for revision surgery is also grafts. I know that you guys are physios, and many of you don't know that much about the difference between a hamstring, patella tendon, quads, and so forth. And you should know that hamstrings are not as good as patella tendon as far as risk of revision is concerned. So that's the one thing that we look at. We also look at the age. The younger the patient, they have much higher risk for revisions. This is a busy slide, so let me go to the next one, this one here. So here you have patella tendon, here you have quadricep tendon, and if you look at pre-op dates and post-op numbers, that is 2 years down the road, they're almost the same. They're a little bit better quads, actually. So quad tendon is quite good when you start out like this. However, when you look at revisions, the quad tendons have a much higher revision rate than the hamstrings or the patella tendons. Those two, this is the quad. And if you look at the numbers, after 2 years, quad tendons has about 5% revision rate, whereas the tendon bone only has 1.6, so it's a big difference there. So you probably shouldn't do that. But if you look at this one as well, again, 2-year revision rates, quad tendon, patella tendons. Here you can see quad tendon has a revision rate at 2 years, so about 4% in patients that are younger than 20 years age. Patella tendon and hamstrings, much better. If you look at really active patients with tendon scores for more than 6, meaning they are playing football and tennis and handball, things like that, you get really a big chance of having revisions, 10% revision after 2 years. That is not very good, actually. And then it has been illustrated here. We have the hand tendons up here, higher risk of revisions, whereas the patellar tendon is there. So there is a difference between the two, not a major difference, but there is some difference. And even although this was in Scandinavia, here you have the US, exactly the same thing. So here you have the hamstrings, the patellar tendon, and the allografts. So the allografts are not good when it comes to revision rates. At, for example, 6-7 years, very high revision rates especially in younger people. So you should not use allografts in young people. Now, this was very big injury. This was a very big study. 46,000 ACL reconstructions in Scandinavia. It showed much higher revision rates in hamstrings compared to patellar tendons. So that's not a good idea to use. So patellar tendon, however, was used only in about 15%. 85% had hamstrings. So, that's a very strange thing because it's not as good. So the overall risk for a revision is significantly lower in the patellar tendon group. And that was in all age groups, didn't really matter. Now, here you have the three grafts. Here's the quads, here's the hamstrings, and here's the patellar tendon. And the surgeons need to be familiar with all three of these. They need to, because that is very independent on, or that's very dependent on what kind of sport the patient is doing. Every surgeon doing an ACL, they should be able to use all these kind of grafts. That's very important. And if you look at the fact that it's much higher failure rate in hamstrings than in patellar tendons, and then you look at what we have done in Norway. We used to do a lot of hamstrings here. So here you have the years, and we did more and more of hamstrings until up here where we got the results. I just showed you that patellar tendon is probably better. Then we took out the hamstrings and did patellar tendon instead, which is probably much smarter, at least in all our pivoting sports, football, team handball, basketball, and so forth. Now, the Danish registry has done a very good study on quads compared to the others. And they show, like this, that they do pretty well when it comes to subjective feeling or quality of life, for example, but they have a much higher revision rate. So that is an important thing. So if you're going to do quads, you need to be experienced. You need to have a lot of training in labs before you start doing that part of the thing. Now, there's also, as you know, many different ways of fixing the grafts in the knee joints. I'll just show you here all the different kinds that we have today. These are only a few of them. And we've done studies where you look at which ones are good, which ones are not so good, and which ones are bad. And I'll just show you one slide of that here. Here's the patellar tendon, which is a reference. Very good, use an interference screw. Then you look at, for example, endobutton, which is hamstrings usually, and a screw up there. It has much higher revision rates. And the button plus BioSure has the highest revision rate, 7 times more than in patellar tendon with interference screws. And then these are in between. So this really makes a difference which kind of fixation you use for your femur side and also for your tibial side. It's very important that the surgeons are aware of this. Now, the registry studies are, I think that they add a lot to our knowledge. It really has transformed the way we do surgery in Scandinavia and in part the US and Canada as well. And I think that the main thing here, patellar tendon graft, it's been shown to be very good. The cartilage and meniscus repair, worst outcome. Even if you do cartilage repairs and meniscus repair, you don't get as a good result as if you don't only have an isolated ACL injury. That's important to know. There are benefits versus drawbacks. The drawback is, of course, the cost a little bit to have a registry. In Norway, it costs about 150,000 euros a year to run our registry. and there's some extra work for the surgeons because they have to fill out the forms, and also the patient, of course, has to do that. Now, I want to end this by asking you if you know what graft you have to have after an ACL to win a gold medal in the Olympics. And I know that I've been asked this all the time by your colleagues, and the answer is actually this: that well, she won gold medal in snowboard with bone, patellar tendon bone. He won the gold medal in Super G with the hamstrings, and he won the gold medal in twice actually with the quadriceps tendon in downhill skiing. So you can both win gold and silver. This is from the Olympics in Pyeongchang, and this is from the last World Championship here. They won gold and silver there also in downhill skiing. So the point I'm trying to make is that all these can function. All the three different grafts can function, but you have to have a good surgeon, good rehab, and you have to have lots of knowledge on how to fix these grafts and how to use them the right way. The final things I'd like to mention to you is that we are developing artificial intelligence when it comes to registry. And, because we have so many ACL patients in the registry, 70,000 in Scandinavia, we're able to use machine learning to look at many things, especially this. We can now more accurately predict outcome following ACL reconstructions. And if you look at this final slide here, we can, and our goals with machine learning now is that we can identify the most important factors associated with outcome. We can also rank people related to their risk of having a poor outcome. And when you're sitting there in your clinic with your patient, you have the computer in front of you, you can estimate the probability of failure for that patient and then make them change their habits to try to have their ACL in the knee much longer. So I know this was very quick and there's a lot of information in it, but I can tell you that the ACL registry is a good thing. I know that's difficult to put that together in the countries like Italy and France and Spain. But it is possible. At least I think you should have a registry locally in your hospital so that you can follow your patient and know what your results are. Thank you.
Thanks, Lars, for your presentation. Very interesting topic, and also incredible to see the amount of data that you've been collecting and all the valuable information and that we can take from the registry. And obviously, thanks again, and we look forward to seeing you later in our Q&A.
Mm-hmm.
And now to our next speaker. I'm excited to have here today with us Bart Dingenen from Belgium. Bart is a physiotherapist and researcher at Hasselt University in Brussels. In 2015, he finished his PhD at Leuven University, which was focused on postural control in relation to ACL injuries and chronic ankle instability. He continued his postdoctoral research activities at Leuven University and Hasselt University in Belgium, where he focused on the assessment and rehabilitation of ACL injuries and running-related injuries. He's published numerous papers in international peer-reviewed journals, and he frequently presents at national and international conferences. He works clinically as a sport physiotherapist at the private practice Motion to Balance in Genk, Belgium, where he's mainly consulted in relation to lower limb injury rehabilitation and prevention. I will hand over to Bart now. His topic is how to optimize rehabilitation and return to sport decision-making after ACL injury and reconstruction.
Okay, thank you, Paolo, for the introduction and for the invitation as well to present here today on this very interesting online knee congress. So I'm going to talk today about possible strategies to optimize rehab and return to sport decision-making after ACL injury and ACL reconstruction. So as Paula already mentioned, basically currently I'm mainly working as a physical therapist, and I combine these activities, these clinical activities, with an academic position at Hasselt University in Belgium, indeed, and a position where we're also teaching for the physical therapy students at the university, but also externally. So I think Lee already mentioned in his presentation that overall the outcomes after ACL injury and reconstruction are not that good in terms of return to sports rates, in terms of re-injury rates, symptoms, OA risk, etc. So we should do better. We can say that as clinicians, as people who work with ACL patients, that we have to critically think how we are treating these patients, and mainly maybe we can do better, or we should do better. So the question is then how? Of course, there are many factors always involved in the rehab process. But my point of today here is that high quality rehab is essential. So I know there are also other factors involved, such as we heard in the previous presentation, like the operation itself with ACL reconstruction, but what happens afterwards is my topic of today. And I'm trying to make or to bridge here what we know from research towards what we try to apply here in clinical practice. So my presentation here today is more like some clinical advices that I want to share with you to optimize the outcome after ACL reconstruction. So before you begin, it's really essential to know for each individual where you're working with, where you want to go. What is your end goal? So you should begin with the end in mind. That means that if you have a football player, for example, at a certain level, you know that they have to deal with certain movements, actions, etc. on the field, which can be totally different between levels of play or between different sports. So if you know the end goal, you can count backwards, and then you can make a step-by-step progression during rehab. So that's your starting point. And I think what we, or in general, what we have been doing too much is guessing during rehab. So we know that if we just say, okay, today I'm going to do this exercise and tomorrow I go to the next phase, but actually I don't have a real clear plan, well, this might be a less optimal rehab strategy. What we should try to achieve during rehab is make good assessments on a regular basis, and based on these assessments we try to guide our training process. And during training we really have to train hard and smart. That's a little bit the summary. Of course, in practice it takes a long way to cover, but training hard and smart is really necessary to achieve good outcomes. And I think if you have a clear plan, because we have a long way to go, if you have a clear plan, it's much easier for you as a physical therapist or surgeon or whoever is involved in the process, but also for the patient to structure and to get the compliance very high. So the story starts, of course, with the ACL injury, and then the rehab starts, because we know pre-op rehab is essential to achieve good outcomes after ACL surgery, if there is an ACL surgery, of course, which is in the figure here. And then we start with criterion-based post-op rehab, which is one continuum with repeated testing that it's not only done at the end of the whole rehab process, but we repeatedly test, and therefore we use a criterion-based post-op rehabilitation, and we always try to work together. Everyone involved in the process can have different experiences and expertise, so we really have to work together before you go to a gradual periodized return to sport and follow-up. So this is a little bit like the perfect view or the most optimal view, starting from a pre-op, even though that we know that a lot of patients don't do any pre-op rehab, but we know that this could be a more optimal way of a rehab continuum. And what is really essential is that you do the basics very well. So what I see often in rehab is that a lot of therapists, without blaming anyone, of course, but a lot of therapists want to go too fast to too fancy things in rehab. So without doing the basics very well, this is asking for problems. And doing the basics well, that means that you have a clear goal for each phase, for each session, for each exercise. And based on these goals, you really have a detailed exercise prescription to achieve these goals. And if you just look at the ACSM guidelines on training and strength and conditioning, strength training, well, there are some basic guidelines we just have to try to implement in clinical practice. Be specific, give overload step by step, and apply variation. But I can tell you, if we would apply these principles in a better way, we would probably have better results. Another point of attention is that I think Lee already mentioned the importance of quad strengthening in the OA population, but this is also essential in the ACL rehab, that we really develop quadriceps strength, and that we don't only focus on the high force, low velocity exercises, but also progress to high velocity, low force exercises. Think about power development, reactive strength, rate of force development, etc. These are often things that we don't cover enough, I think, during rehab. And we really have to try to optimize the whole force velocity profile and not only focus on the high force, low velocity. But if we look at studies, the outcomes, even in patients who returned to sport, then we see that around 3 in 4 of those patients who return to sport fail to achieve basic physical criteria. And basic physical criteria, I mean then having a, for example, quadriceps strength of 90% compared to the non-injured limb, or having a hop test of 90%. What we see that even if we consider this as basic criteria, that most patients don't achieve these criteria, which is disappointing. So what could be the reason for that? In line with Lee's presentation, we know that often our physical therapy is underloaded. And if we underload our patients and progress too fast to a next phase, we have unprepared athletes. Unprepared athletes meaning that we do activities with our patients while they're actually not really prepared to handle the demand of the tasks. For example, running or jumping or sport-specific activities, which can lead to overloading and finally disappointing outcomes such as pain or at the end maybe re-injury. So again, and this is again in line with Lee's presentation, we have to do the basics very well. And what is then functional? A lot of therapists argue we have to do functional training. But probably the most functional you can do, especially in the mid phase of rehab, is getting your isolated strengths at high as possible before integrating into very high demanding activities. Because that's the problem. They often not prepared to do so, and then they come and run into problems. Okay, the next topic I want to discuss here today is how can we make the transition from more closed tasks, so as we see here on the left, to more open environments as we have during, for example, basketball or any ball sports. So how do we make the transition towards on-field situations? And I want you to look now at this video here where Carlos Tevez, some of you might still know him, Argentinian football player here at Manchester City, who has a video on his head while playing football. And what you see here is that the environment is constantly different. So you have teammates, you have the ball, you have opponents next to you. So this is what we call moving in open environments. The players have to adapt themselves constantly towards these changed environments. So this means that if we want to get back to physical performance, it's not enough to just focus on the individual characteristics itself, but we also have to make sure that the individual can adapt to different tasks, different environments. And this perception action coupling is really essential in these dynamic sports. So if we look a little bit at literature, we know that traditionally we mainly focus on a biomechanical approach, which is still essential, but we also know that there are a lot of sensory motor things going on after ACL reconstruction and injury, which are maybe not covered very well during rehab. So we have to use or we try to use now, a combined approach where we target both of these aspects. So what we traditionally do is more here on the right of the figure, that we try to recover mainly the physical factors after ACL reconstruction. Think about strength, mobility, etc. But if we really want to make a transition towards on-field situations, I think it's also important to take into account that there are contextual factors, environmental factors, but also cognitive and perceptual issues involved when you want to get back to the pitch or the field. So how do we approach that? Well, there are some suggestions in literature that we can improve our rehab by not only focusing on strength and power development, etc. This is of course very important, but also to integrate more novel motor learning strategies and integrate what we call more sensory motor integration training, where we try to achieve more automatic movement control while trying to achieve that these players are not that visual dependent anymore, and they can really make the transition to on-field situations. So this combination of more novel motor learning strategies and the combination of sensory motor integration training and cognitive training might lead to improved performance. So this is only a newer field of research the last couple of, let's say, 10 years. And I think we will learn more and more on that in the next couple of years, and also in terms of results and indeed outcomes after the ACL reconstruction. And when we focus on motor learning, and when we really want to improve motor performance and improve learning, we know from motor learning theories, for example here from Gabriele Wulff, that at the end we don't want to make the player focusing on his injured body part itself. We want an athlete going back to the field still thinking about the knee. How much is my knee going in or out, or is my knee moving well? No, we don't want to make the athlete thinking about the movement or on itself. We want to make sure that the athlete is focusing on the game again. And we know that certain motor learning strategies can help to achieve this. For example, using external focus of attention, or giving the player more autonomy, etc. These things can help to decrease self-focus and focus on the task goal to improve performance and motor learning. So here you see some more advanced drills to integrate later on in rehab, where we try to move on towards more unplanned multidirectional movements, where you see that we can add a cognitive component and we can add some visual motor interactions in these rehab practices. We want to make the player moving more in open environments, and we want to make sure that we apply variation, progression, we make it very challenging, and also we want to make it fun for the athletes to train. And this can be done with some lights, or what we can make it even more functional if we do it with 2 or 3 players in the environment. Okay, this is one aspect. Another aspect is to focus then on, again, to achieving good outcomes after rehab, is bridging the gap between rehab and return to sport, meaning that we also have to apply on-field rehabilitation. And this is often neglected, or we take often a too short period to complete this on-field rehab. What do we do then? We at the end stage and on-field rehab, we really want to make sure that we complete or maximize our neuromuscular performance. We want to improve our movement quality in these more open environments. We want to improve or get back to the sport skills, and also make sure that the players build up again a good or appropriate workload by also physical conditioning. So my final point is then, okay, all these things are nice to know, but when can I return to sport? That's a key question I think each player has when they do rehab. When can I return to sport? And we can just make then a very long discussion. What is return to sport? I think return to sport is only one aspect. What we finally want to achieve is return to performance. And how do we do that? Well, it's not only what we propose here in this paper is that we don't only do that here at the end, but by repeatedly testing the athletes, we want to make sure that there is a gradual, step-by-step layered process by finally leading them to a gradual integration into sport. And just some basic things to pay attention to are indeed the completeness of neuromuscular performance. Think about maximal strength, but also think about reactive strength, rate of force development, etc., which we often forget. Movement quality is also a point that we maybe underestimate sometimes. We know from studies that there are 2 main things that we see when we look at movement quality. One is interlimb compensations, meaning that we typically underload the injured limb and loading more the non-injured limb. And another strategy that we actually see across a variety of tasks is a intralimb, or actually compensation where the players tend to unload the knee, leading to decreased external knee flexion moments, often by limited knee flexion, and often what we see here, for example, in this left limb, which is injured, by using more trunk flexion, again, leading to a shorter position or lever arm between your knee axis and your ground reaction force factor. So the knee flexion moment is often decreased, maybe because of a quadriceps deficit, or maybe because of other factors. The same for all dynamic tasks such as cutting. So depending on the tasks or the sports, you can develop both bilateral or double leg and single leg tasks in multiple directions. Next, we want to make sure that the player is developing his sport-specific skills again, and we want to make sure that the athlete has built an appropriate workload. So it's not, we are not doing a very good job, I think, when we just thinking, okay, we develop the quad strength again, but when the player has done nothing of conditioning or not in line with those factors that they need, we still might get into problem. And then I come back to my first point, begin with the end in mind, meaning that you have to know the sports, you have to know the athletes, you have to know what you're preparing for if you want to work towards a certain workload, to avoid peaks and problems afterwards. Next point is patient-reported outcomes. We heard already in the previous presentation some of them. Psychological readiness is also one of them, which we can used within a more biopsychosocial perspective. So we know that both psychological, social, and contextual factors can also play a role when returning to sport. It's not only about the physical aspects. There are questionnaires available that we can use. Here are some suggestions. There are no strict values, but so some suggestions in literature on cutoff values that you might be able to use in terms of psychological outcomes or other patient-reported outcome measures that you might be able to use. Of course, there are also others available. Clinical examination, of course, we want to make sure that there's a full range of motion, no pain, no swelling, no abnormal laxity, but I think these are more traditional criteria that all of you might be familiar with. Time after injury is still an important issue. So we know that criteria are important. We want to make sure that the patient can handle the specific requirements of the sport, but still there is something as a biological healing process, which we think takes at least 9 months. So we also know that biological processes also play a role next to your physical recovery after injury. And at last, there are social and contextual factors which also play a role. Think about timing of the season, the player, the coach, etc., who also can have, of course, an influence on the final decision making. So again, to finalize here, we can say ACL rehab is a team approach. We have to work together, trainers, coaches, physical therapists, strength and conditioning coaches, surgeons, parents, the patient itself, of course, in the middle. We all have to work together. And when we work together, I think we can do a better job than we used to do. But we have some steps to take, I think. Thank you for your attention. And I think we can go back to Paulo now.
Okay, thank you very much, Bart, for your presentation. We can say we love the fact you covered an incredible number of topics in a single presentation, to be fairly honest with you. That was amazing.
It's always difficult.
Yeah, but that was impressive. Especially, I would like to say, also knowing Paulo is thinking probably the same, that a couple of things that you highlighted are very important. The first thing as a physiotherapist, we need to do the basics well. We don't sometimes just jump into fancy stuff, and it was a good thing that you highlighted that. And also, just not in relation to me, we have the luxury to cooperate with a lot of researchers, and a lot of you guys always start with this idea that we have to have the end, the target in mind from the beginning, otherwise we are not progressing through the final destination. This is something that was brilliantly highlighted, so thank you very much about that.
Thank you.
So what's going to happen now is that we asked our people that follow our pages on social networks, LaFisioterapia.net, NOVAVIA Project, and Guida Galattica for Fisioterapisti, for questions. So they knew the topics you would have introduced to us today. And so we have individual questions now, and also some group questions. They came in different languages from different countries, so we're gonna literally translate them real time for you guys. So the first question is for Lee. It's coming from Luca in Italy, and is in relation to prevention in this specific case. So if players, let's say a team, a rugby team, how can you handle, and what would you suggest in terms of how to implement a prevention program when you know in advance that these people train on different surfaces? So they play on grass, but they train on artificial turf. Is this a risk factor? What would you do?
There's probably two things with prevention. One is the age group. So obviously a younger age group, you probably want to build a lot more of the movement skills. With the older age group, who are perhaps training at high volume, you've got to consider how much work they're already doing, and if you're doing a prevention program on top of their work, how much you're overloading them. So you're increasing the risk of their injury just by adding fatigue. So prevention is really useful, but there's probably some context. And if we get to surface, the research, and they've done some good research down at Aspetar, Atto Tolfsen and his colleagues, looking at friction. And so what you're probably doing is that in terms of this knee problem, an ACL problem, the higher the friction environment, the greater the challenge to the ACL. So that's why some of the indoor sports, and I'm sure Lars is far more familiar with handball and things like that than I am, but the indoor sports suffer more with the high friction environment. So it's probably making sure you train them on the worst case scenario. So for instance, they may play on a grass pitch, which is reasonably yielding, or they may play on a grass pitch like some of the Premiership football teams, which is incredibly well prepared and is a very high friction environment. So you get high ball speeds and very good grip. So it's probably understanding what is likely to be their most challenging environment and making sure they have done some of their work in the most challenging environment. And again, that could just take the form of a warm-up activity, or it could take the form of a very formal structured prevention program. It depends on time and load. But consider the friction of the surface would be my thing, and go to the worst surface for friction, ideally, to train on.
Thanks, Lee. Next questions to Lars. This question comes from Spain, from Jorge. He wants to know if it's possible to access the ACL registry, and also who can do secondary use of the data, and what are the requirements for this use?
Well, by secondary use, you mean probably that anyone in Spain, for example, can ask the registry for data and use that, even though it's Norwegian data or Swedish data. And that's possible. There's been many other countries that have talked to us, and they have developed in their development of their own ACL registry. They've been using our data as a background. And for example, if you'd like to see the difference between two types of graphs or two types of fixations and stuff like that, you can ask our registry for the data, and you can use those. So those are open. You just have to present a protocol. That's the only thing, and you will be able to do that.
Okay, perfect. Thanks.
Okay, now we have a question again from Spain, from Manu, actually, for Bart. You already covered this, but maybe you want to talk about this in a broader way. Anyway, the question was in relation to how much time, that was the question, how much time do you consider necessary before you carry out the first test to decide, or anyway, to have take a decision around return to sport? And you already explained that it's a gradual process, but there is still this belief that we do something for a certain amount of time, maybe 6 months, 7 months, and then all of a sudden we do a test battery or whatever. So maybe you want to comment on that.
The question is when you start testing during the year?
Yes, for return to sport. With that in mind.
Well, with that in mind, actually, you do it. You have, like, if you see your patient when they come back to your clinic, you do your monitoring, as Lee already mentioned. But we divide our rehab process in different steps, and the first bigger step is getting out of the first phase, which means 4 to 6 weeks, where you do some basic assessments like knee swelling, like full quadriceps activation, like the mobility of the knee, the gait pattern, etc. These are also already tests that you can do in the whole process. And of course, the tests that you do are dependent on the process. So of course, you don't do the same tests at the end as in the beginning. Of course, it's dependent on the process and on the individual. But you have and there are some protocols available where there are some very specific criteria described. Yeah.
Can I comment on it as well, Bart?
Please.
Because I think that, you know, in the old days, this was all time-based. Now it is all criteria-based, as you've been talking about. But even so, the ligament takes about at least 9 months for it to heal, you know, maybe 80%. You're still not 100%. So then even if you test the patient with your testing at 9 months and your ligament seems to be good, only about 60% of your patients will be able to score full 100% on your testing. So it's a very good question from Spain. When should you test? And in my opinion, it should be after your full rehab in your different categories, but also you should always wait 9 months at least before you do full 100% testing, in my opinion.
Yeah, that's also mentioned in the presentation, that if you take into account some criteria, but you also take into account absolutely the biological healing. And what I just was mentioning is that your tests are dependent on the phase where you are. But the final test, totally agree. Yeah? Yeah. If you look at power development, etc. Yeah, these are more later phase, and even then, I think there is always a time delay in the classic test that we know, and the final step, getting back to sports. So these tests are just, let's say, a green light to get more sport-specific activities, and then you have still a process to go before you have full return to sports, let's say.
Thanks. We go back to Lee now. So this question is from Enrico from the UK. It's about young athletes. So he wants to know, what age can we start to perform heavy load sessions with weights and plyometric work?
Good point.
It's an interesting one. I was part of a consensus statement a few years ago, and the basic, there is some biological and physiological things to consider, which is probably pre-puberty, whether, you know, how much you will get a mass gain anyway from a lot of strength, and whether you should be working on skill. So possibly pre-puberty, it's probably considering skill development, and some of that will be how to develop force, acceleration, agility. But until somebody reaches puberty, where you've probably got the hormonal cascade to gain a lot of advantage from strength gain, there probably isn't added benefit from going heavy. My strength and conditioning colleagues will probably jump all over me for saying that, but biologically, there's probably not a lot of muscle mass you will gain because you've not got the triggers. Not an expert in that by any means. And again, it's probably a graduated load, and looking at the overall profile of the athlete and what are we trying to chase. So if we're looking to improve speed, are they a good runner? Will give you probably as many bangs for your buck as working on acceleration. So rate of force development, yes. Heavy lifting to improve acceleration, probably in a younger age group, probably isn't as useful. If we're using it just as to get bigger and stronger for, say, an impact-based sport like rugby, yes, that is advantageous, but skill is equally advantageous. You evade as many people to win the game as you hit. And so again, it's probably getting the balance right between why we want to gain strength and what other things could be useful in the profile of that athlete to be better at the sport, and finding a balance. I don't think there is an age you cannot start, as long as it is done in a graduated and sensible way and they are taught technique first. But equally, you've got to ask the question as to why, what is the end goal? With Bart's comment, what is the end in mind we're looking to gain here?
Thanks a lot for the answer. And back to Lars again. This question is coming from Rebecca from Italy. And sort of a clinical case, let's say we have a patient with a complete ACL rupture, but potentially a copper, so good stability, good control of the knee. And we know that physiotherapy will possibly help him or her to return to sport with no operation in case. But what if the patient strongly prefer to have surgery and it's asking for that? So its preferences for surgery. What would you say as a surgeon also?
Well, first of all, I have to say that the patient decides, usually. In this case, if the patient is going back to pivoting sports, then I think by pivoting, I mean football, team handball, basketball, so forth. Then he would definitely be having surgery if he wanted to in my country. But we have about 4,000 ACLs a year in Norway. Only 2,000 are being reconstructed, which means that 2,000 are going out in reconstruction. And we've been really showing well that you can cope well if you are a coper with the most of the sports, but not the really heavy pivoting sports. So in that case, the patient really preferred surgery. We sit down with him and explain to him what we will be doing, the rehab, and the positive and negative parts of the whole thing, complications, etc., and the risk of not coming back to sport, because the elite athletes, 85% will be back to their sport, maybe not with the same performance. I agree with you on that one, but they'll still be back. But in amateurs like ourselves, probably only about 40–50% will be back to their sport. Maybe their chance to get back is almost the same as if you don't do the surgery. So all that has to be discussed with the patient. But in the end, the patient will rule when it comes to surgery, isolated ACL, and if he is a coper, he can decide himself.
Perfect, thanks. And now the question for Bart. These questions from Manuel from Spain. I know you touched on this during your presentation, but probably you can give more information. Question is, how much importance do you give to the athlete's psychological readiness to return to sport?
I think we give a more and more importance to the psychological aspect as well, because we know that when you look at the factors determining the fact whether they return to play or not, the psychological aspects are often one of the most important factors coming out in a lot of studies. So definitely it's important, maybe equally as important as a physical recovery. We also have to monitor the psychological recovery after injury, and this can be hugely different between athletes. Some of them are far too motivated or far too confident, while some have really fear of movement, fear of re-injury, etc. So you have really different profiles and curves across the whole rehab process between individuals. So I would say definitely it's really important to monitor it, but also to do something about it when you see a less optimal psychological recovery in your athlete.
Okay, thank you.
That's okay. No.
Let's wait a second. We're going to cut this clip, so no problem. Let's wait for Lars to be back.
I'm here. Don't
worry.
Yeah.
It was a perfect fit, actually, because we were just pausing, so no big deal. Okay, thank you, Bart, for your answer. Now we move on to the group questions. So we have some questions for all of you guys, and I would start from Lars again, because this is somehow links to the last question that we posed to you. So what's the role, if there is such thing, if it plays any role, for bracing in ACL deficient knees that wants to return to play? So not surgical knees, so not operated knees, but did all the rehab. Is it necessary? Is it helpful? What the evidence are saying?
The answer is no. If you have an isolated ACL only, you don't need a brace. A brace cannot prevent pivoting. A brace cannot prevent Lockmans, not much anyway. It can prevent varus and valgus instability. So the only time we use bracing here is that if the patient has a lateral or a posterolateral or a medial injury, and we do that at the same time, or we do not do surgery to them sometimes, then we do it, or if they have a dislocated knee and we've done surgery to that. So we don't really use brace a lot, but I think there are new braces coming up that are being developed as you speak that may be better for ACLs. I know one company who has developed a dynamic brace that I used for isolated ACL knees. So I think in the future there might be a change here. At the moment, we don't use much bracing.
Lee, do you want to add something on this in terms of clinical practice?
I would agree with Lars. The only caveat I probably would put onto that would be the once a year person who goes to a higher level sport, so the once a year skier, or the once a year suddenly goes for a hike in the country, which we're all banned from at the moment. But and it probably links with Bart's comment around the psychology and the confidence it gives them to probably engage in something more sensible. And it doesn't replace the rehabilitation and their strengthening, but some people will not engage optimally in rehabilitation and strengthening. So to give them a brace, so at least they were likely to be more sensible around their use and remember they have a problem knee is not necessarily a bad thing in those circumstances. I would caveat Lars's comment with the once a year ski heroes.
Bart, again, in relation to what Lee said, maybe it never happened to you to use a brace just because the patient felt more sure, even if, safer for them to sport?
No, I agree with Lee, that can happen, especially indeed in those patients who do a certain activity, a high risk activity once in a year or something. I would agree to put a brace on. On the other hand, if they really aim to return to sport, then my opinion would be, okay, you have to train until you don't need a brace anymore, before you return to sport. Could also be a motivation for some of them. But as Lee said, for some, there are no rules for everyone. I think there is always some patients who fit not the group, but that's with everything, I think. But in general, rehab comes first, and then in isolated ACLs especially, and as Lars mentioned, especially in the early phase when you have more complicated multi-ligament injuries, yeah, of course, then it has more role probably.
Perfect. So we go for the next group question. This time is a clinical case. So we imagine there's a professional footballer, 20 years old, with a complete ACL rupture. He's a coper, but he's debating about conservative versus surgical approach because both options have been suggested to him. So he's worried that 3 or 6 months down the line, the conservative is not working and then he will need surgery, but that might then jeopardize his new contract. So what would you suggest in that situation? So Lee, if you want to start for this time.
Unfortunately, context is everything in the world of sport. The reality is why and I'll ignore the Olympic situation for 1 second, why in professional sport we end up going for reconstruction is because we are relatively successful in an elite population at returning them to close to the level in a pretty predictable period of time. As Lars said, somewhere in that 9 to 12 month period, you can guarantee we'll get a player 85+% of players back to within 10-15% of their previous performance. With a conservative approach, we cannot give that level of guarantee. So in elite sport, invariably, surgery will be chosen because of a little bit more certainty. In saying that, in the last 2 Olympics, we've had athletes who performed very well ACL deficient. and have done very well, but they did go on to have ACL surgery after the games. And again, this was more about their perception around long-term disability. And so again, those factors need taken into account, but context is always everything. So
but I think
they'll go for the contract.
I think Lee, you're right. But I think that in England, even in the Premier League, there are a couple of players without an ACL playing. So it can be done, but they are obviously very good copers and they train very hard to be able to do it. But in general, I think you're absolutely right. It's difficult to do pivoting sports on a very high level without an ACL.
Bart, would you like to comment on this?
Well, I think you always have to make distinction between the population. I think if you have someone who can do rehab for 8 hours a day, let's say, or someone who is working 10 hours in a day and has to do some rehab afterwards, that's a totally different situation, as already mentioned. And I think also culture and beliefs play an important role here in the beliefs around having the need to have surgery or not. I think it's a little bit changing over the last couple of years. But still, in general, people are really convinced that they need surgery. Yeah, but even though some are really, in my experience also, some can do quite well when it's isolated. When it's combined injury, I think it's again more difficult to get well. Maybe Lars, you have more experience with that.
You can say that the reason why most people have surgery when they are elite football players or handball players is that the surgeons say they have to have it. And you know, there's really no good documentation that non-operated isolated ACLs cannot function in Premier League because there's only a couple of patients there. Mm-hmm. So it's a little bit hard to say, but it's tough to try it out because you know, in the US and in part of Europe, surgeons will say, okay, if you don't do an ACL in a Premier League player, you will have a cartilage injury because you'll have a meniscal tear and so forth. I am a little bit concerned about that statement. It may not be correct. We don't really know that. So I'd like to see some international national studies on non-operative patients that are doing some pivoting sports. I personally think it's possible if you're a good coper, but I'm not sure. That's why I think it's difficult to go for that at this stage anyway.
Mm-hmm. And Lars, do you think? Oh, sorry, Lars. Do you think there's Lars, do you think there's a difference in culture, maybe in Scandinavia, that they're more open to, because of the studies have also been done there? Okay, one study, the Frobel study there, that the people are more aware of the possibility over there compared to other countries. Do you think there's a difference as well?
There's a huge cultural difference. I used to work in the US for a long time. There, if you have an ACL, there was no talk about non-operative treatment, and that's the same thing now, actually. Whereas in Scandinavia, the patients actually are aware of the fact that they can be treated conservatively, and some of them would like that. And they also know that it takes them a year or two to get back to full knee function if they have their ACL done. So there is a big cultural gap. But in between that, you have Holland, Belgium, to a certain extent England as well, where people are a little bit more in between. So I think the proof will be in the pudding when we get more data out there that it's possible to live doing sports and everything without having an ACL done. At the moment, I think that's a little bit difficult because we don't have all the answers based on facts in the research.
Well, thank you guys for evolving the question in this way and answering this thoroughly. The last question for all of you guys is actually from Paolo and myself, Paolo and I. We both work with knees and athletes, and the thing is sometimes, well, quite often actually, we notice that we tend to test people for return to sport or return to play, let's label as we prefer, not in a way that is responding to the actual conditions in which they will perform those activities. So we could talk probably about this for a couple of hours, but let's limit this discussion about fatigue, because there are a lot of publications around it, also reviews. So what do you think about this in terms of fatiguing people and then testing them to make sure that they are in the closest possible situation to when they will play sport? And do you do this in your clinical practice? Bart, please, can you kick off this?
I think there's indeed a lot of debate on fatigue, but actually the evidence showing that fatigue is a real risk factor for ACL is not really there yet in this moment. It's not there in this moment. So on the other hand, we know that fatigue can change your movement patterns, and we have to make the athlete resilient to fatigue, because they will be fatigued, of course, and they will come in situations where they're fatigued. But fatigue itself is not a risk factor for ACL. But I think that's not the reason why we should not be able to test them in fatigue. There are other good reasons to maybe test them in fatigue conditions, except from saying that you will predict now in a better way whether they get an injury or not, or etc.
But I think we can, if I may interrupt a little bit here, we may get some data now, because after the virus is more or less gone and the leagues start up again, both in football, basketball, team handball, so forth, the number of matches played will be much, much higher than it has been, and the number of training will be less because they don't have time to train so much. And then we'll may see a surge in the number of ACLs in the football leagues, for example, or the next, I would say, if they start to play now, let's say August 1st, and they play a very tough fall season with maybe 3-4 times more matches than they should, then we'll see what happens.
Yes, but then the question is also, what do you consider to be fatigue? And you have acute fatigue, you have chronic fatigue, chronic workload, as you maybe refer to now when you have more games. And what we maybe forget sometimes, if indeed after this lockdown period people would get back to sports, if you haven't been in situations for 4 or 5 months within these complex environments, it's also from a neurological perspective differently. That's often what athletes say. Oh, the play is going very fast when I've been out of the game for a long time. So also in these neurophysiological perspectives, you could argue that a long time out of the game could be less optimal for the athletes, next to the physical fatigue.
And I think that's the limitation of the research which is looked at fatigue. Most of it, certainly the argument Tim Hewitt is putting forward, is ACLs occur at all times of the game. Well, that doesn't take into account, that takes a single construct of time. You could be incredibly acutely fatigued 5 minutes into the game because you've just been involved in repetitive elements of play. You could have played for 40 minutes of the game and you could have been sauntering around in the backfield.
Agree.
So the previous 5 minutes don't seem to be accounted for in this consideration. And as Bart said, the cognitive fatigue is massive. We did a case series which got published. And one of the things which came out of it was just the multifactorial nature of why they got the injury. And quite often we see injuries of players who are reserves and they come onto the pitch. Now that factor would go, they're not fatigued, but they're, as Bart said, they're not up to the speed of play. And so their head is probably exploding with a whole series of factors, which then mean they make a poor decision or they do something wrong. So I think some of the pure researchers, and no offense to Tim et al. In this, are taking a single construct when they're looking at fatigue, and it is multifactorial. And so to answer your rehabilitation question, I feel you need to have made sure the athlete makes good movement decisions in the appropriate circumstance. So we make sure they are cognitively and physically fatigued, both chronically, i.e. work for an hour, but also acutely, where we will hit them with a very intense period of play and expect them to still be able to make good movement decisions. Yep. So it's looking at all the constructs fatigue could be, applying them and still making sure the athlete is making good decisions in terms of movement application.
Yeah, agree.
Good point.
Yeah, and that was the whole point of the question in relation to why we decided with Paolo to step in and ask. Actually, still a question for all of you in relation to fatigue, because a lot of papers are out there, but maybe this could be investigated further. We will see in the future.
Yeah, but you know, if you just one commentary, if you look at return to sport in high-level sports, there is about let's say 40% who cannot make it, something like that. And actually, among regular people not making it, the main reason for not making it is anxiety. They're afraid of their knee, and they feel the knee might be working well, but they have this brain thing, like you're saying, but that you know, this is not good for me. I just can't do it, even though I feel pretty good. And that's the most usual reason for saying that we will quit and play chess instead of football.
Yeah, and Bart's comment around, we're talking a lot about psychology being a big factor, but we then need to ask the question, what aspect of psychology? Is it kinesiophobia? Is it that fear of movement and injury? Is it your fear of, you are a 29, 30-year-old footballer, and it's actually the loss of body image because you can no longer play with the younger guys the way you did, and so actually you don't want to go back because you're going to look off the pace and not as good. Psychology is such a wide area that we shouldn't just go psychology. We really need to ask the next question.
Yeah, and that's a little bit limitation of also, if we just take a questionnaire, sometimes psychological factors are far more diverse than what's in the questionnaire, you know. Based on individual factors, you have maybe a totally different reason why they have psychological issues with, as Lee said, with playing again.
But this has really changed. So when I was with the Olympic team 1984 in Los Angeles, I was the only doctor and there was no psychologist. Now there are 5 full-time psychologists, performance psychologists at the Olympic Center in Oslo, and that's probably not enough. So that has totally changed, and it is changing as we speak almost.
Yeah. Interesting.
Okay, thank you very much for the answer and all the answers up to now. So these basically close off the Congress. So we want to thank you all for joining us, accepting our invitation. So thank you very much, Bart, Lars, and Lee. It's been great having you here, and we are sure people watching this will enjoy your presence and your presentations.
Thank you for inviting us.
A pleasure.
Thank you very much.
Thanks.
And again, that was the online International Knee Congress set up in cooperation between NOVAVIA Project, Guida Galattica per fisioterapisti, and LaFisioterapia.net. And we thank you for being here. We hope this has been helpful and you enjoyed that. And I pass the word and the mic to Paolo to close this off.
Yeah, thanks everyone for registering to the Congress. Thanks again to all the speakers for these amazing presentations. And obviously we will be back with more online events in the future. So please follow us on our pages. So Guida Galattica per fisioterapisti, NOVAVIA Project, and LaFisioterapia.net on social media. Thanks again and goodbye.